We've talked about Acalabrutinib, but let's take a deeper dive. Let's talk about AMPLIFY study where Acalabrutinib is being combined with Venetoclax and Obinutuzumab. John, this looks very exciting. Your thoughts on design and its findings?
AMPLIFY was an exciting study to read out for the first time this year at ASH just a few days ago. This was exciting for practitioners in the US because it might afford and likely will afford the first approval of a oral doublet combination slash triplet combination in the United States, in this case with acalabrutinib. This was a study that looked at three arms: acalabrutinib venetoclax, Venetoclax Obinutuzumab, and against the control chemoimmunotherapy arm of FCR or BR. This excluded patients with deletion 17p because randomizing those patients to chemotherapy is not considered an ethical approach. Those patients were not enrolled or studied. This was 14 cycles of treatment, so 2 cycles of acalabrutinib lead-in, followed by 12 cycles of acalabrutinib venetoclax. The obinutuzumab also started at the same time that the acala did in the AVO arm. And a really powerful, important study on a few things. One, and the primary endpoint here was looking at acalabrutinib venetoclax against chemotherapy. That was all of the power and statistical evaluations were essentially looking at AV versus chemoimmunotherapy and not to be washed out by the AVO components of this, though they have hierarchical evaluations of the triplet combination against chemo as well. And what we saw is that acalabrutinib venetoclax met its primary endpoint by having an improved progression-free survival, as you can see at this IRC 36-month landmarked time point of 76.5 months versus 66.5 months in the chemoimmunotherapy arm. And when you looked at the AVO arm, seeing this signal where adding the antibody can actually improve outcomes in terms of MRD negativity, complete remission rates, and that typically will translate into, with any fixed duration, will translate into a longer-term progression-free survival benefit. So we see the AVO arm perform the best of the three arms at a cost of toxicity. No overall survival difference was really noted at any of these time points. And, I think with the analysis of COVID and things like that, we can talk about that, but it's performing very well tolerated in terms of its toxicity profile comparatively to what we might have seen with ibrutinib and venetoclax. Well managed. Most patients, again, younger patient, more fit population. I think the median age was in the mid 60s on this study. For the most part, patients completed all of the 14 cycles and very few dose reductions or discontinuations of either or both of the agents of the AV arms.
Right, Joel. Thanks so much for going over that. And rather, this is certainly an exciting study, but as you stated, it comes at a toxicity cost. And especially when you talk about AVO, where you have exhausted everything up front, what is to one use in second line approach, especially when we've been going back and forth that we have utilized Ven in front line, and then we are relying on BTK in the second line and vice versa. Are you utilizing any of this approach or still sticking with what we have at hand?
Yeah, so the triplet, I think, can be nice for a small subset of patients. For those higher risk patients, we do see some improvement in outcomes. And, I think right now it's a discussion that has to be had with the patient, because what we saw in this study is that the addition of the antibody did have increased infection deaths, particularly related to COVID. And it's important to remember that this study started to accrue right when COVID hit, in the meat of 2020, in the meat of 2021, when was the vast majority of these patients were accruing. It seemed like most of these toxicities and deaths were occurring while on. They did speak to vaccination impact, that most of the patients who had died had been not vaccinated with the available COVID vaccines. They did some sensitivity analysis that if you took COVID out of the picture, the AVO arm started to look really good. The AV did not have as many infectious deaths, which is a positive for that regimen. The antibody is really adding some immunosuppression here. And I think there was only 8 COVID deaths compared to like 22 or something in the chemotherapy arm and the AVO arm. So a dramatic decrease in that infectious toxicity. So an advantage of AV with the cost of maybe less efficacy, less MRD negativity, translates into slightly lower PFS. No overall survival difference is being noted between the AV or AVO arms. Overall survival starts to look good for all the arms. It's a discussion that will need to be had, but I think what's nice is that AV looks to compare historically well to our other fixed duration approaches like Venetoclax Obinutuzumab, and offers a new treatment that is well tolerated. You don't have to deal with the Obinutuzumab lead-in and the toxicities that come with that. And I think it's a welcome choice for community practitioners, for myself, and in the academic world, seeing CLL patients, that it gives us now some freedom of choice of which approach do we want to take, and a well-tolerated approach. The second question that you had about using all of the drugs in that frontline setting, we don't see much data from this data set about retreatments and mutation analyses and things like that. It's just a little too early. We don't have much information about that, but we have learned from other studies like Captivate, which looked at ibrutinib and venetoclax, and GLOW and some of the studies with ibrutinib, is that upon relapse, we're not seeing resistant mutations. We're seeing patients being able to go back on, mostly from most of the data is just continuous therapy BTK inhibitors, but they're responding and responding for a very long time. They retain sensitivity. My experience enrolling and participating in the Captivate study has led me to believe that these doublets and triplets are very safe because we're not necessarily causing harm to our patient. We are able to salvage them. And if anything, you can argue that it may actually improve the resistance profile because now you're pulsing the patient with treatment. There's less evolutionary pressure to break through. And in fact, it may maintain sensitivity over multiple courses of treatment over the next 10 plus years.
Well, exciting times. We'll see how it all turns out once we have longer term data on this.